in New York, and I'm delighted to welcome you to the 5th and final plenary. The title of the plenary is Advancing Justice and Equity in Sexual and Reproductive Health and Healthcare. And this is going to be sort of closing out the theme of the conference, which has been to think big and make sure that nobody gets left behind in sexual and reproductive health and rights. Before we have our first speaker, I want to just call your attention to this special issue of the Vietnam Journal of Public Health, which was produced for this conference in accordance with the conference themes. You can pick out a copy of it on your way out. So without any further ado, I'm going to introduce our first speaker. Dr. Anderson Stancioli is a health economics advisor at the UNFPA Asia Pacific Regional Office. He's responsible for providing technical assistance on health financing to promote equitable and efficient sexual and reproductive health and rights service delivery. Before that, he was at the Gates Foundation, where he led the creation of a portfolio management system to provide visibility into the global health product development pipeline. He also played a key role in managing the relationship with the Institute for Health Metrics and Evaluation at the University of Washington. So please join me in welcoming our first plenary speaker.
Thanks so much, Jennifer, and good afternoon, everyone. It's a pleasure to be here. It's my first time attending this conference, and it's been very interesting and instructive for me. And today, I wanted to talk to you about a recent work that we did on sexual and reproductive health and universal health coverage in the Asia-Pacific region. And I'll try to be brief. There are three main points that I want to cover. First, setting the context of how do we think about UHC and sexual and reproductive health. Then I'll talk to you a little bit about the results of a recent study that we have done in 6 countries in the region and come to the conclusions and recommendations. I know many of the people here are very familiar with UNFPA, but I think it is useful to take a moment to talk about the 3 transformative goals that we have as part of the current strategic plan. And they focus on 0 maternal deaths, 0 unmet need for family planning, and 0 harmful practices, including gender-based violence and FGM and other harmful practices. So I wanted also to touch on the issue of how do we look at the global context of the SDGs and how they may reflect on the issues of SRH services and UHC. We heard about in some of the other sessions about that. I think there are 3 key targets that I think we need to highlight, as you can see in the slide. The SDG 3.1 is about maternal mortality, and there's a target to reduce that to an average of 70 per 100,000 live births across the world. And we know that in this region, many countries are not there yet. And I think what our analysis is showing is that with the current rate of improvement, they're probably not going to be able to reach that level. So when you think about maternal mortality, it's still very much a very important issue for the countries in this region. While we have countries that are middle income, they're relatively well off, but it's really important to make the point that we're not there yet. There is still a long way to go for most countries, so there's a really big importance in keeping that in how, especially national governments, set their priorities. SDG 3.7 is about universal access to sexual and reproductive health care services, and that includes a whole range of services, and I'm going to come back to that in a little bit. And then SDG 3.8, it's about universal health coverage. So it talks about financial risk protection, essential health care services, and affordability of essential care and medicines for all. I think for most countries, they are really interested in how they can reach UHC, and there has been a lot of discussion about that and a lot of supporting support, and there's a big momentum at the moment. Now, when we think about this, the question that we're trying to answer is, fine, so we have UHC as a big priority for many countries that has a lot of ownership and a lot of support. How is it being able to really address SRH needs? And I have to say we're really looking at SRH services at this point, so the issue of rights, it's a little bit broader, but I think it's still important to consider the issue of services. How are they being covered or not covered under UHC? And what are some of the issues that countries need to take into account as they push toward this very worthy goal? A lot of people are very familiar with this diagram to the left, which shows the 3 dimensions of universal health coverage, and that has been really useful to galvanize countries to action. So it's looking about coverage of services in the right-hand side, the coverage of population, ensuring that especially the most vulnerable people are covered. And on the vertical axis is looking at the financial risk protection, so how much people have to pay for accessing services. So there are different ways we can consider this issue, and if we start from the functions of the health system's financing, that gets us to intermediary objectives and the goals. And as I said, the goal is really to provide access to a wide range of services to a wide range of people at an affordable cost, so that they are not facing financial hardship to access those services. So fine. So what does that mean then when we look at sexual and reproductive health care? And that's where some of the challenges start to appear. I think this is showing that to some extent, many of the things that are part of SRH, they may not fit completely within the current schemes of UHC. And what we are saying is that while some of the broader issues may need to be reflected in broader policies, there's also need to look more carefully at some of the health services that should be part of UHC, but as I'll show in some of the analysis that we have done, it may not be there, quite there yet. And just to remind, the issues related to SRH are very complex. They may cut across different sectors, which are not only covered within UHC generally. I think this is one way to start to understand how that plays out in the region. We developed this index that looks at access to services by looking at adolescent pregnancies, skilled birth attendance, and unmet need for family planning in the vertical, and comparing that to the financial risk protection that we see across countries by looking at out-of-pocket payment. So what this is showing is that while we have some countries like Thailand, which is really a star performer, you have very low exposure to financial risk and very high access to services in general for SRH. There are many countries where, as you can see, there's still a long way to go. And I think what we're trying to highlight to our counterparts is this is an area that needs more attention. Here, something that is very familiar to all of you, as you can see, there has been great progress in expanding access to these services. We have here contraceptive prevalence rate, antenatal care, and skilled birth attendance. So overall in the region, we have seen a lot of progress from 2005 up to 2013. But I think also what this is not showing are the big inequities and differences that we also observe within countries, which I'll come back to later. And let's get right to there. I think our study, we looked at 6 countries. We looked at Bangladesh, Cambodia, Indonesia, Mongolia, Thailand, and Vietnam. And the reason we chose those countries is that they are at different stages in terms of developing and implementing universal health coverage, and they would provide a nice snapshot of what are the concerns along those different stages. In terms of the scope, we're looking at a selected number of services. We're not able to do the full scope right now, so it's mostly about family planning, including emergency contraception and abortion care, antenatal care, maternal health services, STI diagnosis and treatment, HPV vaccination, cervical cancer screening and treatment, and GBV services from the health sector. And what we see in this first slide that I'm showing you is, if you look at family planning, overall there's very good utilization across the region. So in most countries actually, with the exception of Indonesia, the contraceptive prevalence rate among the poorest quintiles of the population is higher than average. So that's very positive. However, when you start to unpack that a bit more and you look, for example, at adolescent fertility, you'll see there is a very substantial and sizable gap between the richest and the poorest. And we think that this is related to lack of access to services, which will at the core of what we're talking about with UHC. When we look at antenatal care, there has been substantial improvement over time, but there's still some gaps, especially in the low-income countries. Skilled birth attendance, kind of similar, but I think at a lower coverage and with even bigger equity gaps. So these are things that need to be clearly highlighted, because when you talk about the average rates, it might look very good, but when you start to unpack things, that's where the big issues start to arise. This is, I think, an interesting look at what are the types of services that are included under UHC, and I just want to point some of the things that you see. So, unfortunately, it's not very clear in the slides, but what we can see is that in most countries, there are significant gaps in terms of what types of services are covered by UHC schemes. So when you look, for example, at family planning, emergency contraception, most countries are not yet covering those as part of their main UHC schemes, and that's a reason for concern. And the other thing that I also want to highlight is that the coverage of those schemes is also not 100% in most cases. So, which means that even though we're looking at the regulations as such, the actual implementation are not quite there yet. I have to go a little bit quicker. On this one, I just wanted to say there's not a lot of information about financial risk protection for SRH, but what we can see clearly is that countries with more actually with less public investment in health, they have more out-of-pocket payment and lower coverage, which is, again, a concern. So quickly, I just wanted to briefly mention the main conclusions and recommendations we have. I think the first thing that I already noticed is that SRH goes beyond the health sector. And there's a big danger in, when you look at the UHC only, that some of the services may not be covered and captured adequately. And I think some of the things that I would call out here is the issue of adolescent fertility, which is not only about services, it also involves issues of social norms, rights, access to information. Similarly to gender-based violence, a big part of the response takes place outside the health sector. So how do we call attention to that fact so that it doesn't get lost into policymakers' minds? The second thing, which I think is very important, is that in general, UHC is not giving appropriate attention to prevention. So a country like Thailand, which is very advanced and has reached the UHC for a long time, is just now starting to realize the importance of investing in prevention. So things like HPV vaccination, we still have very low rates of utilization. Contraceptives, special adolescents, as I mentioned. And I think also this is an important opportunity to highlight that the SRH can actually contribute to improving the sustainability and financial effectiveness of UHC. So if you can promote those preventive services, that can lead to better outcomes and less costs. I think the third thing is that we see part of the UHC discourse is to improve the efficiency of the system, reduce fragmentation, have better outcomes. better value for money, which is really good, but also important to ensure that vulnerable groups are not left out of the equation. So having appropriate mechanisms to include people that may not be able to afford healthcare premiums, avoiding health user fees at the point of care, are important design issues that need to be considered. And then finally, the issue of coverage of adolescents. I know it's been part throughout of the conference, and you know much better than I do about that. And then finally, the issue that universal health coverage is often not universal. So how do we ensure that really there's no one left behind? Looking at ethnic minorities, the coverage for migrants, refugees. There are many cases, good examples in some countries. And I think also recognizing that the SDG goals, in order for them to be reached, everybody in the countries will need to see overall improvement. So to conclude, I think what we're trying to show is that universal health coverage and SRH are two very important agendas for our governments, but they need to be working together. We need to ensure the complementarities and also promote actions that where this efficiency and equity can come together to improve the overall performance. Thank you so much.
Thank you so much, Dr. Stancioli, both for your presentation and for sticking so obediently to the time allotted. So our next speaker is Dr. Adriana Martin-Hilber. Dr. Hilber is a senior specialist in the sexual and reproductive health and the deputy head of the Sexual and Reproductive Health Unit of the Swiss Center of International Health at the Swiss Tropical and Public Health Institute, based in Basel, Switzerland. She has over 25 years of experience in policy advocacy, implementation, research, and project management of large implementation and research projects in developing countries.
Thank you. Dear colleagues and friends and advocates, it's a real pleasure to be here, and I want to thank the organizing committee and Leah particularly for inviting me to come and participate in this great event. I have seen the conference change and evolve over the years, and I can say that this year's conference reflects the coming of age of your efforts. So thank you for having me, and I look forward to seeing you at the next event. But before I get started, I wanted to explain my choice of picture as the backdrop. A spider on her web, on a fence, ironically shaped as a heart. I thought this image well reflected what I wanted to say here today, that as practitioners, we have worked to engage young people, to welcome them warmly, the heart, yet the offer is somehow spiked, the fence. As practitioners, we may feel we offer a safety net, the web, offering protection to adolescents who may see our offer perhaps as less than beneficent guardian, the spider. So let's discuss where we are, what we have offered, what has been the effect, and where do we go from here. So in this presentation, we're going to be looking at how healthy and informed are young people in the Asia-Pacific region. I won't focus too heavily on this because Anderson has already reviewed a lot of the data, so we can go quickly there. And then we'll look at what are we doing about it. What are the interventions, approaches, their effectiveness, and their reach? And then what's the problem? Have we translated that strategic advice, data, and participation into more effective programming? And where do we go from here? The walls, the fences, the potholes, and how can we overcome them? First, let's look at the epidemiological situation as a reflection of socioeconomic, gender, and other forms of inequity in the Asia-Pacific region. And as I said, I'm going to go quickly now because you just saw it. Here's the adolescent birth rate, where things have largely remained the same. Some countries have done markedly better, like Vietnam, others less so. While the reasons for the trends may differ, the net effect is similar. The same or more adolescent pregnancies that are risky and ultimately limit young women's opportunities in their future. And as was mentioned previously, the issue of the disparities within countries, unfortunately, is also growing. If we look at maternal mortality, the mortality rates of girls remain unacceptably high, even if progress has been made in recent years. SDRs are on the rise, with 16 to 19% of sexually active 15 to 19-year-old girls and young women in Indonesia, Mongolia, and Nauru reporting symptoms or having had an STI in the last 12 months. And recent data from UNAIDS indicates that the figures are not improving. Many presenters have spoken about violence against women. While all are unacceptable, the over 30% figure from East Timor are particularly alarming and may signal deep problems in society where patriarchal traditions and a history of armed conflict, as seen in Timor-Leste, contribute to a widespread violence against women. And as also discussed previously this week, the HIV prevalence rate among young people, particularly among marginalized populations, is not getting any better. I'm going to skip over these a little bit. We talked about body mass index and some of the problems and the adolescents not living with either biological parent. And while the reasons may be related to migration and other issues, they're also associated with some of the highest adolescent pregnancy rates in the region. And then finally, of course, there are the underlying issues that put young women and girls in a position of vulnerability. Early marriage and the accompanying early childbearing rates in the region, particularly in some countries, remain staggeringly high. So what does this mean for health inequities in healthcare services and the provision of services? How do these statistics relate to the services they need, want, and are offered? Access to family planning for adolescents has a mixed record with recognized improvements in recent years. Despite progress on unmet need in some countries, particularly among 20 to 24-year-olds, there still remains a significant gap. Barriers to accessing healthcare services when you're sick. When we review why 15 to 19-year-olds don't go to the health services when they are sick, the issues are quite clear, but only partially what we would expect. Naturally, cost, as was mentioned previously, and permission from parents or guardians remains issues that we well know. But there is also an overriding issue of not wanting to go alone. Surely that is something we could have overcome, isn't it? I mean, we have been working on these programs for years, and if they're afraid to go, it seems something that we could have done something more about. And when we look at skilled birth attendants, maternal and newborn care, culture and belief in the system play a part. We note, for example, that where there is early marriage and high adolescent pregnancy, there is also low utilization of skilled attendants at birth, compounding the life-threatening maternal complications these young people face. So that's for the data part. Now we know what the problem is. What are we doing about it? Well, we have lots of ideas. Globally, the evidence has been reviewed, synthesized, summarized, cataloged, dumbed down, made into checklists, algorithms, guidance, best practices, infographics, notes for scaling up, to name a few. Each of us that work on programming for adolescent health has seen some, if not all, of these documents and tried diligently to take their advice. Indeed, many of us have participated in these processes to ensure that we know what to do to meet the information and service needs of young people. The recent WHO and UN partners' Global Accelerated Action for Adolescent Health, or the AHA strategy, has provided a strong summary of what is needed to improve programming for young people. Recommended actions include situation analysis, adolescent health profiling, stakeholder mapping, engaging adolescents in the design, implementation, and evaluation of programs, multi-sectoral interventions, age-appropriate interventions, and respect for rights, gender, and the special needs of marginalized populations. I think we know many of these and know that they're extremely important if we're going to have an effective adolescent health program. In terms of life skills education and information, in terms of SRH and HIV information and education, it has been provided to in and out of school adolescents and young people through a variety of means, but all basically aiming to deliver life skills education and information and/or comprehensive sexuality education, or some form thereof. Ways in which education and information have been delivered has varied, but most include some kind of peer or teacher-led intervention sessions delivered in schools, whether they be public or private, vocational, universities, police, military academies, children living in boarding schools or other institutions, and out of school. We all know the list: school clubs, extracurricular activities, youth centers, discrete peer education programs, hotlines, media, social media, radio programs, safe spaces. We're all aware of that because, and I personally, because I've tried, I think, most of them. When we think of, but to meet the health needs of young people, we have also tried numerous approaches over the years, including a variety of forms of youth-friendly services and service packages, usually accompanied by extensive training of providers to deliver services that are friendly, confidential, they respect privacy, allow for anonymity, reduce service access barriers such as fees, physical access, the time when they are available, and so on, separate entrances. All of these things we know and we have tried in a variety of different forms and formats. And right now we have an enabling environment. There is a particular moment in time, I think Sophia Gruskin said yesterday, we were talking about the very special point in time where we do have a lot of opportunities and, of course, the converse constraints politically. There's heightened attention to adolescent in recent years due to global advocacy and recognition of the triple dividend of investing in youth and how that has yielded increased political commitment globally and in countries. And I would say that not the least of that is due to the global strategy for women, children, and now adolescent health and the SDGs. This in turn has provided the necessary funding and support for multi-sectoral programs and projects that have successfully identified and addressed barriers such as restrictive parent and spousal consent laws in some countries. I know in the Asia-Pacific region there was a full review of legal barriers that were tackled by UNFPA and others. There is also now more awareness of the evidence base of what works, including the importance of youth participation in programs that affect them. This is increasingly being done through the support to youth initiatives, campaigns, and advisory panels. So if we know what to do, we have the guidance, we are out there in the field, we are working with young people, what's the problem? Why is the strategic advice, data, participation not yielding better numbers, better services, and healthier, more informed young people in our region? And here, I guess, is where we start to make excuses, usually involving lack of funding, government lethargy, corruption, bureaucracy, social and cultural norms, the rise of fundamentalism, discrimination, and so on. I would like, however, to pose an alternative explanation for what's going on. The barriers we know, and perhaps some we don't know because young people don't share them with us, continue to create walls, fences, and potholes on the road to making services accessible, available, appropriate, and most importantly, used by the young people they are intended for. The messages we provide through our education and information efforts also often misses the mark because they have often been negotiated so heavily that the messages become narrow, single issue, pregnancy prevention, HIV prevention, abortion, and frankly, rather dry. They're just not sexy. That's it. In the age of tweets and YouTube clips, who has time to listen and concentrate on the messages from a teacher or nurse you don't trust, even if they're really well trained? In our programming, and I would say mine as well, naturally, despite best intentions, we often miss the mark. If the mark is services and programs that are available, appropriate, accessible, and of quality to young people, then too often we fall short. Our projects, if we are honest, are excellent. Pilots with great potential, if we modify a few things. They are strategies and approaches that tick the boxes, but perhaps had to compromise a bit to meet targets, deadlines, available funding cycles, partners we had to include. And as a result, we end up offering a good service package that isn't as anonymous and confidential as they should be. We have providers and teachers that have been trained and maybe even retrained but still have not fully managed to overcome their biases to deliver truly non-discriminatory, respectful information or care, or we manage to secure insurance coverage for key services for youth, perhaps even without legal restrictions, but the organization of the services themselves proved to be insurmountable hurdles for the young people to overcome. A big part of the problem is the context. Services have not been designed for young people. They are not friendly by definition. Teacher, parents, providers are not the go-to people young people want to speak to with their private, worrisome, and even exciting personal information. The messengers are not necessarily trusted. In addition, I think most young people would say, they don't understand. We adults have to recognize that we probably don't understand. And everywhere, shame, shyness, stigma dominates the list of concerns that limit young people's ability to reach out and benefit from the education, information, and services offered that they may come across. And as a result, we end up serving young people that are not those in greatest need, and perhaps would have found a way to get the service and education without our intervention. Middle and upper class kids, and not the most marginalized, nor those with special needs. Small projects and true exceptions exist and are around and need to be highlighted more. So I go back to the problem. There are barriers. We know, mainly, what they are. We have been told many times by young people themselves what they are. We also understand what is needed to overcome them, though admittedly more challenging to deliver than a drop-in center or a peer education program. So why don't we have more success? Why can't we speed up the progress? I think it's because we are not really listening. We hear the issues, but perhaps we think we know best. We can't change, or are so entrenched in our strategies and approaches that we do not create enough flexibility within what we are doing to take the suggestion that our, quote, clients, young people themselves, have said are needed for the program or service to be effective. Certainly it's complicated, but one can appreciate that it can appear that they are not being heard. So where do we go from here? How do we break down the walls and fences that we are told are insurmountable hurdles for young people? I propose partnership, not patrimony. We have a chance to stand in partnership with young people to decide together how to best meet their needs in ways they want to be reached. The leaders and advocates are all around us. We just have to give value to their voices and trust they know what matters to them and how to reach them. We do it in other spheres. Why not in development programming? I'll give you the Coca-Cola example. We talk of public-private partnerships, so perhaps we can learn something from the private sector. Everywhere in the world, almost everywhere, you can get a Coca-Cola. They know their clients, they know where they live, they know how to access them, they know what kind of soft drinks they like, they even know the color of the can. It's all been well studied. Indeed, Coca-Cola reaches the last mile. So why are we not so successful? Why are they so successful, even if they may have an awful product? Because they listen to their clients. They take their advice, adapt their systems accordingly. We have to start listening and adapt ourselves, our programs, our investments to the needs if we are really to leave no one behind. Fundamentally, it's about respect for young people, for their views and perspectives, and confidence in their capacity to guide us in efforts to support them. It's only through true respect and partnership that young people will become actors and agents, not merely beneficiaries in their own health, and we together can improve their health and well-being. Thank you.
Thank you so much. Our next speaker will be talking about women's bodies, bodily rights, and claims for social justice. Shireen Huq is honorary coordinator of the Bangladesh component of a multi-country project on women's health rights advocacy partnership, as well as founder of Nari Poko. And I'm not going to take up any more of her time. You can read her very long bio in the program.
Hello and good afternoon for all those of you who have stayed back the hardcore. I understand a lot of people are out in the islands. My body, my right. At the end of the opening ceremony of this conference, representatives of the youth conference came through the auditorium shouting, "My body, my right." I was reminded of our own journey in articulating that demand. In 1988, 87 or 88, 3 decades ago, when the women's rights organization I represent, Nari Pokho, was less than 5 years old, we were confronted with a tragic incident whereby a young woman, a mother of 3, seeking contraceptive advice at a government model family planning clinic right in the heart of the capital city, died of tetanus infection. The woman had opted for a permanent method and agreed to undergo a sterilization operation. The service providers were in haste and went ahead with the operation, with the surgery, without ensuring tetanus protection. What had triggered this behavior? It was fear of losing a potential client. Incentive payments were attached to the number of sterilization cases handled. This incident led us to a long discussion around what it is that we want for ourselves, what kind of choices, and what kind of rights. It led us to develop a manifesto of sorts, elaborating our demands in relation to our bodies, our ability to reproduce, and our right to health and well-being. It was the result of nearly 8 months of debate and discussion. We refer to this discussion as Shorir Amar, Siddhanto Amar, my body, my decision. We mobilized against the so-called incentives tied to the number of sterilizations and IUDs, officially known as compensation payments, and finally succeeded in having these withdrawn. It's a long story, I won't go into it. Now let's fast forward to 1994 and the run-up to Cairo. We decided that here, the theme for our International Women's Day program for 1994 would be Shorir Amar, Siddhanto Amar, my body, my decision. This meant going public with the slogan in a very big way. But first, we would have to convince our sister organizations in the International Women's Day Committee, many of whom either felt shy of such a slogan, which at that time was considered a bit too bold, but ultimately we won that one, but not without argument. The reaction from progressive and educated men was that of shock and horror, quickly turning into hostile verbal attacks. Are you referring to free sex? No, it means we will decide who we want to have sex with, and when, and where. Scandal, scandal. This made many progressive and educated women think that we had gone a bit too far. So misogyny is hegemonic. Fast forward again, in 2011, and on the 40th year of Bangladesh's independence, am I too close to this mic? I can hear it going boom, boom. Okay. In 2011, on the 40th year of Bangladesh's independence, I was invited to give the keynote address at the conference of the British Association of South Asian Studies. I decided to focus on what independence had meant for women, including the hundreds and thousands of women who had suffered sexual assault and rape at the hands of the Pakistan Army during our liberation war in 1971. The title I chose for my talk was My Body, My Life, Whose Rights? Our bodies are central to the oppression we are born into, and our bodies remain central to the complex weave of discrimination and disrespect that are our constant companions. Thus, body became central to the framework for our activism. Now, to look at this diagram, this is one of our frameworks for Nari Pokho's activism. Well, our goal is obviously to have laws that are just and non-discriminatory. In other words, to have substantive equality. So on the one hand, it's about rights and about dignity. On the other hand, it's about well-being. And central to all this is our body, our sexuality, and our health. And by that we mean both physical well-being, we mean both physical well-being, livelihood, and safety. And the rights and dignity is, of course, vested in us as persons. And, of course, our bodies are also capable of labor. And there again, the question of dignity comes up and just returns to labor. And then we have two areas of activism. One is healthcare, and of course the 4 standard criteria for good healthcare, that it should be accessible, it should be of high quality, it should be acceptable to communities and to women, and above all, it should be affordable. But even more important are the social and cultural rules that govern our lives, which is about trying to change and bring transformation in values, attitudes, and behavior. Can we move to the next slide? Oh, I have to do it? I don't know how to do this. Can you do this? That's the next slide. Yeah. Oh, okay.
Just back there was the next
Okay, okay, okay. Thank you. I'm a techno dummy. So how do we go about realizing our rights? How do we go about achieving non-discrimination? Whether it's in relation to health or whether it's in relation to labor, central to it again is our body and our sexuality. And of central concern is safety and just returns and dignity of labor. So our movement strategies are about building voice and mobilizing, having widespread mobilization, and of course to have a conceptual clarity around rights and how we transform, how we realize those rights, in what way do we go about claiming our rights. So voice and mobilization is about confronting values, confronting attitudes, and confronting behavior that are misogynistic, that undervalue women, and that treat women as objects or as property, and behavior that is sexist. So claims are not only legal claims. There's a lot of advocacy work to be done around bringing about policy change, and a lot of bargaining to be done to bring about changes in interpersonal relationships, and of course litigation, which is going to the courts and seeking redress through the legal process. Cairo was a turning point that we all rejoiced in. However, what we are seeing today is a backslide, and not only in my country, but in many countries in the world. So, as our young friends have put it, we have to say loud and clear, my body, my right. Shorir amar, odhikar amar. I want to end by paying tribute to all the ICPD warriors, including our own comrade Nasreen Haq, who gave clarity, passion, and perseverance to our movement, and the youth of today who will stop the backslide for sure. Thank you.
Thank you so much. And our final speaker before we have some time for Q&A and then move seamlessly into the closing ceremony. We'll be speaking about harnessing the power of social norms, culture, and religion to uphold sexual and reproductive health and rights. Dr. Natalia Kanem is UNFPA Headquarter Executive Director.
My dear sisters and brothers, the delegates to this 9th Asia-Pacific Conference on Reproductive and Sexual Health and Rights, representatives of the host government, Vietnam, whom I thank and we all thank for your warmth and your hospitality. Fellow panelists, thank you. Activists and people of courage and perseverance, anyone who's different and proud of it, and the dynamic young people here present, I am delighted to be here with you at this closing action of our conference, standing here as the new Executive Director of the United Nations Population Fund, UNFPA, a responsibility that I'm really honored to take up. And I assume it following the untimely loss of Dr. Babatunde Oshotimehin earlier this year. Thank you, Leah, for the acknowledgement of Dr. Babatunde at the opening of this conference. He was a passionate advocate for the issues that we've been discussing here over the past several days. And it's a wide umbrella of sexual and reproductive health and rights, as we've just heard, which covers issues that lie at the nexus of social norms, of culture, of religion, of law, of justice, of equity, not only in the delivery, but also in the receipt of these sexual and reproductive health care services. So to advance justice and equity in sexual and reproductive health is part and parcel of changing legal, cultural, and religious barriers. And much of this you've been discussing at this very important conference. I would like to say that there is an atmosphere of newness. Where there is reaction, there's also positive action. For the United Nations, this is a new year with new leadership. Our Secretary General, Antonio Guterres, just in one example, has committed himself and the United Nations to an end to impunity for sexual exploitation and abuse, and also to full gender parity in the halls of the United Nations. So what I would like to talk to you about is advancing justice and equity in sexual and reproductive health and rights from our perspective in UNFPA and what I call future casting. What kind of future is it that we're creating for Asia and the Pacific, and indeed for the world? And we pose this question at a critical time. The answer to that sweeping question, what kind of future, lies in great part in how we care for the girls of today. In particular, the more than 325 million girls who are aged 10 to 19 across this beautiful region, Asia Pacific. This region and the world embarked on the 2030 Agenda for Sustainable Development. It's underpinned by the 17 Sustainable Development Goals, and we've said that we seek a life of dignity for all, to truly leave no one behind. And at UNFPA, we're embarking on our new strategic plan next year. We will fulfill 3 transformational zero goals in this region and elsewhere. 0 preventable maternal death, and everything that underlies a death, because for every death, there are hundreds of injuries and misfortunes. Second, 0 unmet need for family planning. And again, the question of agency, of rights, of autonomy is something that we're discussing, not only in these halls, but in communities across this country, across the region, and rightfully across the world. So 0 unmet need for family planning, and 0 gender-based violence and harmful practices, which is the reason that I am in Orange today, because like you, these 16 days of activism against gender-based violence and the movement that the hashtag #MeToo represents across the world is that we have to raise our voices and object when a girl or a woman, a man, anyone is subjected to violence. But the epidemic of violence against women and girls shows no sign of subsiding, and quite the contrary. So we base all of our work on a platform of population data, development, and evidence. And the 3 goals that I mentioned, which were formed in concert with many of you as stakeholders in the program of action that emerged from the 1994 International Conference on Population and Development in Cairo, which I was privileged to attend, as some of you also were. It continues to guide our work because it puts women's rights and human rights at the center. And the aim is to shift policy from paper into communities and action into women's lives. That's why it remains relevant now, and it will continue to be relevant more than ever. You know, it's said that the moon moves slowly, but it covers the town. So my anxiety is, can that slowness please be accelerated so that what we achieve gets done more quickly? To get to 0 maternal deaths. In the past 50 years, there really has been progress, and the number of women who die from complications of pregnancy or childbirth has fallen nearly by half. Still, today, with all the advances in medical technology, more than 300,000 women die globally each year from maternal mortality-related causes, and that means over 200 a day right here in the Asia-Pacific region. Tragic and preventable. Skilled birth attendants with backup emergency obstetric care is really crucial. And we applaud Vietnam as a shining example. You reached the MDG 5 on maternal mortality ahead of time. But even before pregnancy and childbirth, every woman and girl should fully enjoy her right to freely decide when, whether, and how far apart she wishes to space children that she wants to bear. Planning and spacing, still key to reducing maternal deaths. The second transformative goal is on 0 unmet need for family planning, because there's still 214 million women who want to delay their childbearing. And why should they lack access to quality services and supplies, including modern contraception? Among them are 6.3 million sexually active adolescent girls in Asia and the Pacific region. Without the expression of their rights and without quality services for these precious girls, we will continue to have the estimated 3.6 million unsafe abortions among young women in this region every year. And we will see millions of new cases of sexually transmitted infection, and these combined epidemics and calamities have a profound impact on the health and lives of the women and girls, of children, of adults. We have fetal and neonatal death, cervical and other cancers, infertility, HIV risk, physical, psychological, and social consequences that can severely compromise the quality of life of those who are affected. And while economic factors are indeed a major contributor to sexual and reproductive health inequity, so too are these norms, the patriarchal and social norms that are often wrapped up in the guise of culture. Culture is not static. Culture changes every moment of every day. And so should the taboos about discussing sexuality. Thank you, Michael Tan. So meeting the diverse SRH needs of men and adolescent boys also has to be something that we attend to. These are the partners of the girls and women. They're partners of each other. And not leaving them behind is an effective way to promote sexual and reproductive health and rights for all. Thank you. For the goal number 3, which is zero violence and harmful practices against women and girls, I only have one slide, so I'll refer to it once it comes up. The zero violence and harmful practices against women and girls is urgent and quite of the moment. Today, for example, the UN Foundation has published my opinion piece on the movement that's being labeled #MeToo. And first, I just want to say a word about sex ratio at birth, the topic of a very exciting session at this conference. Globally, on average, 105 boys will be born for every 100 girls. And the survival rate for the male infant is slightly less than that for the female infant. So 105 to 100 is the natural sex ratio, male to female, at birth. However, as a side effect of this technology that can identify the gender of the fetus, as we know, there is a growing gender bias sex selection in some countries. In some places, the ratio now stands at over 120 boys to 100 girls. And I've heard as high as 128 in places in this region, leading to the fact that there are more than 117 million missing women, a lot of them in China and India, other places as well. And this is a manifestation of persistent gender discrimination and son preference. Another example would be the violence that is child marriage and adolescent pregnancy, some of which is coerced. This jeopardizes a girl's chance of achieving her potential. And in developing countries, including in our region here, 1 in 3 girls is married before the age of 18. 1 in 9 is married under the age of 15. Some 5.4 million adolescent pregnancies occur every year, threatening the health and well-being of girls and of their children and truncating their life chances. Sexually active, unmarried adolescents and young people also have rights, and they should have the information and means to avoid pregnancy and unsafe abortion as they demand. And lastly, I just want to say that the ugly issue of gender-based violence, an estimated 1 in 3 women experiencing some form of violence in her lifetime, and in some parts of our region, the prevalence is even higher, linked again to patriarchal attitudes and norms that used to be perpetuated generation after generation. But the young people of today, 1.8 billion strong, whom I call the SDG generation, have a good chance of putting a stop to some of this. Survivors of such violence can and do suffer sexual and reproductive health consequences: the forced and unwanted pregnancy, the unsafe abortion, the traumatic fistula, and infection, including HIV. In Timor-Leste, almost 1/4 of all teenage girls pregnant and having a baby by the time they're 20 years old. And 20% of them are married by the time they're 18. So even though premarital sex is supposedly forbidden, the evidence, the facts staring us in the face is that most teen pregnancies there occur before marriage. And one of our empowerment workshops for teen mothers in Timor-Leste, which UNFPA fields in concert with our partner, Plan International, that's where we met Lucia. She entered into a relationship with her much older teacher, and much to her surprise, she got pregnant. Lucia simply did not know a thing about sex. Thereafter, her family forced her to get married before the baby arrived, in their words, to save the situation. In mostly Catholic Timor-Leste, like so many countries, there is a comprehensive sexuality education curriculum. It's seldom taught. Teachers are embarrassed. Some of them actually rip the pages out of the textbook entirely. And without access to education and information, let alone services or supplies, not surprising, is it, that the teen pregnancy rate is so high. So I believe that our programs have to insist on being able to give accurate, timely information that young people are demanding, and that we have to have that dialogue and bridge building with every religion and every culture to be able to reach that goal. In Bangladesh, which is conservative and Islamic, we've heard that there are triumphs that have been recorded in the country, and it's a large youthful population. There we have Generation Breakthrough. It's a project which UNFPA supports to empower young girls and boys. It teaches gender equality, respect for diversity and inclusiveness, and awareness of these patriarchal and religious norms that all too often can impede rights and well-being of women and girls. And this program, Generation Breakthrough, engages religious schools and clerics in imparting teachings, often using Quranic scripture, to reiterate and strengthen lessons in gender equality and rights, and very positive results there. I like the story of 17-year-old Muhammad, who told us how his mom would give him the best piece of fish. And she would say, "You will be taking care of us in our old age. You need this to sharpen your brain." And his little sisters got the leftovers. But today, Muhammad is a Generation Breakthrough feminist man, a member who fights for gender equality, and he advocates that girls can do and be whatever boys can do and be. And it's a message which is reinforced by the local madrasa. This is a human right, the expression of happy, healthy sexuality. And it's an equity issue and a justice issue as governments, as NGOs, as communities, as citizens, as the people affected ourselves, demand that everyone, including persons of diverse sexual orientation, any gender identity, that all of our rights be upheld. Why should certain actions be criminalized and safety denied to anyone? Truly leaving no one behind. That's the principle of inclusivity. And there is no place for stigma and discrimination, especially in healthcare settings. Not when it's based on sex, race, ethnicity, mental health condition, disability, gender identity, HIV status, whatever it is, it's unacceptable. It denies people their right to health. Moreover, at times there is a lack of respect for the rights of health workers themselves, and that affects ability to be able to provide services and can actually be harmful to the health of the health worker. Governments are ultimately accountable for ensuring non-discrimination in healthcare. This region, the Asia Pacific, has some wonderful examples of community empowerment of sex workers, of people who inject drugs, and people of diverse sexual orientation and gender identity. Asta Parivar is one that I know of. It's a sex workers collective in Mumbai, and it brings together community-based organizations to advocate for health and legal rights of sex workers, including anyone living with HIV. And this results in change at the local level that can then be scaled up, replicated nationally and throughout the region. So I like to cite these examples. The Asia Pacific Coalition on Male Sexual Health, APCOM, is another one based in Bangkok. And they're a regional civil society partnership with the United Nations overall, advocates for the rights and well-being of men who have sex with men through the lens of HIV prevention and treatment. These are just a few of the stories of the challenge and the opportunity that demonstrate how laws, social norms, culture, and religion can influence the sexual and reproductive health and rights, equity, and equality of billions of our fellow human beings. Each, to me, is an example of perseverance, of partnership, of sticking together. Sticks in a bundle do not break. When we band together in partnership, we certainly can succeed, and it was great to have examples of that in this panel this afternoon, of people who are not ever going to give up, because the fundamental issue is my body, my rights. Economic inequality does divide people. There are certain countries of haves and have-nots. Inequalities in sexual and reproductive health and rights and gender inequality can divide people into cans and cannots. An adolescent girl who cannot enjoy her sexual and reproductive rights is a girl who cannot stay healthy. She cannot complete her education. She can't find decent work outside the home without support, and she won't be able to chart her own economic future. The State of World Population Report, published last month by UNFPA and entitled Worlds Apart and available online, is path-breaking because it looks at this inequality within countries in terms of sexual and reproductive health and rights and how that can disenfranchise untold millions of women. It also bolsters the social and economic systems that enable a privileged few to float to the top and stay there, while the vast majority fall to the bottom. This type of inequality robs individuals of their rights, and it denies whole nations the foundations for development that a united, equitable society would represent. So when we come back to my original question, what kind of future do we wish for Asia and the Pacific, and what will it take to create it? We heard some examples of solutions earlier, and I would say that knowing that by 2030, when the SDGs will be achieved, hopefully, adolescent girls of today will form a significant proportion of that workforce as leaders, as innovators, as entrepreneurs, as teachers, and much more. Many will also be mothers and caregivers for a new generation and for the parental aging generation. Let's not leave a single one of these girls behind. Let us equip her to craft her own future. Now, my slide. Imagine a girl who is standing at a fork in the road. I'd like to have the slide back. Can you go backwards? And on one path of this fork in the road, can we go in the other direction? Slide number 1 was showing the green path, which was a path of an adolescent girl, and we can decide in which direction she can go. The green path shows school and higher education, gainful employment that is free of sexual harassment, and adolescence where sexuality can be discussed without taboos. Adult marriage, yes. Security of place. Union with a partner of her choice, where her sexuality can be enjoyed, devoid of violence. She can have healthy children if and when she chooses to have them, and the ability to invest resources for the well-being of her children. And this is all part of the cycle of life, leading her to a secure old age, right? That's a good demographic dividend. The other path, hopefully the path not taken, is too often the fate of many people that we know. Child or early marriage, leaving school, a pregnancy that's early or unplanned, unsafe, risky childbirth, violence, abuse, HIV, other STIs, informal employment, none at all, erratic, hostility at home, the possibility of displacement, and no pension, no security in old age. If this girl is disabled or she's a refugee, just multiply the vulnerabilities. So for adolescent girls to take their space in 2030 as an adult woman and to be a formidable force for the good, they need our support. They need our support to overcome income inequalities and discrimination on any front. Why should the world be increasingly unequal? Let's not stop until we change that. To change the balance of power, to create opportunity, to ensure rights, including the right to sexual and reproductive health. When you have young people that are a quarter of the world's population, these young people, you young people, you're connected to each other and to the world around us as never before. Yet young people have needs, and they have dreams, and these dreams cannot wait. Technology, connectivity, instant communication, that can really up our game in terms of communication for change, raising social awareness, and getting to that scale. So I say to you as a young person, never give up. The hashtag #MeToo movement is confronting widespread sexual harassment and abuse, spreading around the world, including right here in Asia and the Pacific. And I also say to those women, keep your courage up, persevere, don't give up. It's important to strengthen our ability to tackle these demographic and population issues. This is the noble purpose of public health. When you have a population that's aging, that's a concern for many countries in this region, then we have to recognize that healthy aging has to begin with healthy youth. And healthy youth has to begin with safe, planned pregnancy. My body, my decision, my right. That's the cycle of life. That's the beauty of life, generation following generation. And for myself, my involvement with this region over more than 2 decades brings me here in front of you with a lot of confidence and a lot of excitement for the upcoming 2 years. We're going to have some debates next year at the Conference on Population and Development, looking at CSW and the status of women. And coming up to ICPD plus 25 in 2019, and the Beijing Conference plus 25 in 2020. And I think if we plan together and if we stick together, we're not going to break. We're going to advance this proposition, and so many women are going to benefit from our ability to take courage, not to give up, to raise our voices, to help them raise their own voices. So to you, all the government officials, civil society partners, you're from a faith-based organization, whoever we are, partnering together, we're stronger. The young people who are gathered here today are going to have that spark ignited to understand that they can lead, they can help lead this region to come together. They'll be part of that open, frank, strategic dialogue. I think that working well together, we will be able to cast aside harmful laws, norms, and practices. And we have seen that arc of history so far. The anxiety is to accelerate the progress and move forward and never to move back. Let us persevere to accelerate progress on sexual and reproductive health and rights for all. So together we build a future where 0 is the only acceptable number, 0 deaths in childbirth, 0 unmet need for family planning, and certainly 0 violence and harmful practices against women and girls. And I include child marriage and female genital mutilation in that violence. It will be a world where we fulfill the hopes and dreams for a future that we will create here in the Asia-Pacific region and everywhere, where absolutely no one is left behind. So never give up. Thank you very much.
Thank you so much, Dr. Khanum. So we have a couple of minutes for questions and comments from the audience, if there are microphones out there. And then I believe that the 5 of us are going to gracefully exit the stage. I think that there's a hand over here. And please introduce yourself when the microphone is on.
Hello, good afternoon. This is the first one to check. I'm Professor Manju Chugani from India. And thank you so much for a wonderful session. All speakers spoke so well and passionately. I'm an academician actually, midwife. And I would like to say that we have sexual and reproductive health. We need to combine it from the beginning because it's behavior, attitude, thinking, which starts from the pre-service period. If we are concentrating on only after they come out, the health workers should be having this kind of attitude and that kind of, specifically the healthcare providers, cadres, different cadres, for example, nursing, doctors, other, what do you call that, other disciplines like homeopathy doctor, alternative system of medicine doctors, all these people should have this component as very important component in their curriculum itself, so that they are sensitized to it, they know it, it comes into their thinking and it comes as a routine, not as especially some organization working for sexual and reproductive health. I feel that it should become a part of the system, not as special one which they have to really do effort, because it's high time. Starting from 1988, we have come a long way. Now it should be a part of the normal stream in programs as well as in education system. Thank you.
So are there more comments? I see there's one down here in the middle.
Thank you. Good afternoon. This is Khalidi Yasmin from Medistopes, Bangladesh. I have two questions to the last presenter. You have covered lots of things to overcome the challenges. However, in Bangladesh, we have an adolescent strategy now that was published in 2017, and Bangladesh government also trying to establish the adolescent health corners in the service centers. We found that the menstrual hygiene management now is a great challenge for us. If you can incorporate or recommend some things for that, and for ICT-based communication system, 24 hours hotline, because they suffer maximum time for secrecy and privacy to share the adolescent-based issues. And last one, to involve the media in that platform. Thank you.
Okay, so we'll take one or two more questions. I see there's two. Well, you were first. So down in the bottom in the middle, but or the person with the microphone.
I'm Faizi from UNFP Afghanistan. My question is actually that in the main barrier for access of adolescent and youth, particularly to sexual education, is the parents. But all our focus is mainly on training of teachers, development curriculums. If someone share experience how we can work with the parents, because these parents are the judges, these parents are the principal of school, these parents is prime minister, these parents is the minister. So if we work with the parents to convince them, because we do not have resistance from the student in school. The main barrier is the parents, when they know that in school they are teaching sexuality education or such topics, they are prohibiting or stopping sending their children to that school. So if someone share experience how we can work to convince parents that sexuality education is an important thing for future of their children. Thank you.
And so one of our colleagues down here in the front has been very patiently waiting, and then we'll go to the panelists.
Good afternoon. Thank you, Shirin Appa, for sharing your long history and struggle for women development in Bangladesh. I was just wondering about recent activities in Bangladesh, especially when we have, so many organizations, kind of very and they are doing different activities in different areas. So I will appreciate your commentary on a particular topic. Like, do you consider or do you think that in the recent activities we are missing the activist part in Bangladesh context? Thank you. Like the political engagement of the other organizations, or we are just taking this as a project, and missing the kind of the movement part of in this particular context. Thank you.
Okay, so we have about 5 minutes because I think some of our panelists have to leave to catch a plane. So.
Well, look, we appreciate all of these comments and questions, and I actually think there's so much experience in this room. I'll just take a couple. I like the question about menstrual hygiene, and it's very clear that this is a barrier for young women to go to school. The rituals that can surround the hocus pocus around the blood ritual, etc. And also, if you are running for your life as a displaced person, without what UNFPA calls a dignity kit that provides you with sanitary napkins and hygiene, cleanliness implements, now you're even more miserable than you were before. But earlier in the conference, the question of sex and sexuality came up, and I think that menstruation is yet another taboo which it's not polite to mention at the dinner table or whatever. But every month, hello, women of childbearing age have that experience. So I salute those organizations, NGOs, UNFPA also, who look at menstruation as normal, natural, desirable, and wonderful. And I like the idea of celebrating first menstruation. I've been privileged to attend ceremonies like the Apache in Southwest USA. When the girl starts menstruating, her father goes and knocks on every door in the village to say, guess what? My daughter is on the path to womanhood. And then there are years of learning the lore, the ritual, the vegetation, et cetera, how to build your own teepee. So, there are good dimensions to culture, but for menstruation, typically that's not what I'm familiar with as a Latin American. So I really think you're right that we need to speak more openly about this and more often and attend to the needs so that girls can go to school without feeling embarrassment. Your point about ICT and media, I think, was well elucidated, and I agree strongly that the ability to communicate in simple language rather than a lot of jargon that you need a PhD to understand. And I mean, the more highly educated you are, the more you value the power of a simple story. And I think we saw that in some of the presentations today. And every 10-year-old girl has to understand what we're talking about. This is all for her. That's why we're all here. And of course, the young man that's going to be her partner, especially when we talk about violence. I salute those media projects, the mobile phone apps, everything that we're delivering so that girls can scream when something goes wrong, and so boys can also support them on the sports field, in the community, et cetera, to protect their sister, their mother, their friend. We also did not say enough about midwives, so I'm glad that the professor spoke up. Midwives save lives. My anxiety right now, because UNFPA is on the front lines in Myanmar and Bangladesh right now. We're working in South Sudan. We're there in Iraq and in Syria. I was in Amman, I think a week or two ago. The sexualization of violence and the horrors of rape and other instruments that are being used, to me, like a torture against women and girls, and often boys can be affected as well, means that the same way the midwife gives community attention, we need to understand how the person is affected and also how communities can receive and welcome them back without stigmatizing and pointing fingers at them. So just to close quickly, I want to say on the parents' issue, it's a point that's very well taken. I think the family is the frame that is being used, sadly, more often to try to set back some of the gains that we have. My focus and my attention is on the person who is the rights holder. The rest of us as duty bearers must do our best, and parents are duty bearers. But if that person knows their rights, that's who I'm depending on to defend their ability to have their whole expression as a human being. So sometimes parents are going to be advocates, other times parents are going to try to control someone else's body and someone else's sexuality, and we always have to vote with the girl who has made her decision so that she can be safe in her passage through to adulthood and a happy future. Thank you.
On menstrual hygiene, I just wanted to say that I come from a region in South Asia where we still have the primitive practice of, in Nepal, what is called chopadi, which is when a young girl or woman is menstruating, she has to go and sleep in a little makeshift hut during the time of her menstruation. And the number of women who have been killed by snake bite as a result is not insignificant. But the good news is that earlier this year, the Nepal High Court has actually ruled it to be illegal. But so it's a first step, because to rule it illegal is the first step. Then there is, of course, a long process of actually getting people to abide by it. But it's a good first step. On the issue of parents, in Bangladesh we have incorporated into school curriculum many years ago what is called family life education. But we have found in our own work that in many schools the teachers are reluctant to engage with students on those few pages. So they will either staple them, or they'll say, now you read this on your own at home. So they are not comfortable discussing these issues. So there's a lot has to be done with teachers. So I would say, yes, parents, but I think teachers first, because teachers are duty bearers. And so one can actually hold them accountable if they do not oblige by the instructions. On projects, I think that was your question. Project-based activism. I agree with you that projects cannot replace movements. They can facilitate movements, but they cannot replace movements. And this is something worthwhile for all of us to remember. As you know, of course, there are good projects and which support our movements, which support our advancement, and we must welcome those projects and take advantage of them. But there are also projects which tend to reinforce stereotypes, which tend to put more gatekeepers in the way of girls' and women's advancement, and those are the ones we have to reject loud and clear.
So I'd like to thank the panelists for compelling, thoughtful, and very on-time presentations. Please do not leave. We're going to have a wonderful closing session now, so we're all going to exit stage right, and the panelists will enter.
How long? Not long, right? How short? Definitely not short. 4 days we have been together and investigate in 5 key sub-themes of the conference. I believe that the conference will brought into you many thoughts, many ideas, and many feelings. The nice conference has come to an end today, but definitely there's many actions that need to be taken for tomorrow. To sum up, I would like to invite on stage Ms. Huat Thị Thu Hồng, Co-Chair of International Scientific Committee, Professor Peter Agelton, Member of Scientific Committee, and Ms. Hoàng Tú Anh, Chair of National Scientific Committee, to be on stage and summarize the conference. Thank you.
Hi. Yes. Yeah, good afternoon, everyone. Yes. It's our really great honor to be here this afternoon. And we still have only 1 hour left, so I think maybe many of you also want to go outside to go to see the beautiful island, the bay, but just bear with us in the last 1 hour. Yeah. I think we have a good message together. So, you know, a lot of things that have been happening in the last 4 days, and this time it's brought to us not only a lot of knowledge, but also a lot of emotion. Yeah, happy, angry, upset. Yeah, a lot of things. Yeah, inspiring. So summarizing this conference is almost an impossible task.
Yeah, I agree.
Yeah. So in this 10 minutes, we just aside 10 minutes. So Hồng and I just try to give our reflections.
Yes.
Yeah. And yeah, and so I started the first question. Yeah.
Okay.
So what is your first impressions of this conference?
Well, impression, I have quite a lot of impression, but if you ask me about the first impression, I would say that, well, listening to almost 200 people presented in this conference. I think not only me, but you would see that we made a lot of progress over the last 20 years, starting from our first conference up to now. It's 9th conference. We have made lot of progress. In our region, there's many good progressive policy and law passed. Just recently, right, the Australian passed the law that allowed the same-sex marriage. A few years ago, Vietnam, after long year, removed the Article 10 that banned same-sex marriage. Same-sex marriage has not yet been legalized in Vietnam, but same-sex couple can live together, and it's no longer.
They can get wedding.
Yeah, they can get wedding, and since the family law amended in Vietnam, many same-sex couple made their weddings, beautiful wedding of young men and young women. It's very beautiful. And now in Vietnam, we drafting the law that allow sex reassignment for those who want this. And the Civil Code of Vietnam also amended, allowing those who change their identity can able to get their new document. I think in many other countries also a lot of good things happen. Good policy, progressive law have been passed. Also, a lot of good programs have been designed and implemented. For example, this morning and over the last few days, you listen to many intervention programs
comprehensive sexual education, for example. Yeah, and you can agree with me, you should agree with me that there's increasing recognition of diversity. LGBTIQ communities increasingly invisible because it's less stigma, it's more acceptance, less stigma. Their voice can hurt in many forums. In Vietnam, we have Viet Pride during the last few years. First, it takes place only in Ho Chi Minh City, and then it's moved to Hanoi. And last year,
that's the first impression, and we have only 10 minutes.
Sorry, sorry, I carried away. I'm so excited. Yes. Yeah, we have many good other good things like abortion service. Abortion is very contentious issue, but I think you all agree with me that abortion service is getting safer and safer, right? But still, the service are not accessible for many women who need it. And also, while the recognition of diversity is increasing, still there's a lot of program, a lot of policies still framed within the binary heterosexual normativity. That is the reality in our region, regardless how much we move forward. Yeah, I believe that there's still many things to list here. I want to list one thing that's important. It's about youth leadership and youth participation in decision-making process. Many of you been here in the first day in youth conference. You can see the voice, they are strong, they are very active, they are very inspiring, right? And you can read the youth statement in our website. I'm sure that you will like it.
Yes. And also people with disability, right?
Oh yes, people with disability, migrant people, elderly people, many other groups who used to be marginalized become more and more visible, and they get access to better services. But still, there's still a lot more to do.
Okay, yeah, so your first impression that a lot of progress, but there's still things that we can improve. Okay, thank you. And the next question, if you have to give 3 words about what you have learned in the conference, what should they be?
Wow, it's very, very difficult task because...
I do easy task.
Yeah.
I just ask.
3 words, okay. I try. I was impressed by many of good talk over the last 4 days, but I try to recall those I think most impressive to me. The first is never forget culture. It's what I got from Angela Kelly's presentation, that culture never stays the same. But we used to see culture as barrier. Now we have to learn to see culture as resource. And we have to learn to learn more to turn culture into our advantage rather than barrier as we used to do. It's about culture. There's many other things I want to say, but the second, complicated time. Why is complicated? Because you can see we move 1 or 2 steps forward, we have to make 2 or 3 steps backward. So I can say that national and international politics in our region, in our country, it seems more open, but at the same time, it's closing down. So I can see that why the gap between social groups widening, but at the same time, we have less and less, we have closer space for civil society and for many other marginalized groups to voice their problem. Now, the third? Okay. Okay. I think now I come to the most challenge, most difficulty issue that we both mentioned and we have to face in our work. It's about resource. But I would say that, if I can choose the word, I would say that diversifying resource. Why? Because it's one hand, funding or resources declining from many big donors. But we have more other potential resources. We have to learn how to mobilize a resource from the community, from philanthropy, from our own contribution. That means that we have to learn to diversify or to change or to develop our better strategy and skill to mobilize those potential resources rather than depend on the conventional or traditional resource as we did before. So I think I'm done with your question.
Okay, thank you. I think that's three things that Ho mentioned is, I think, very important, and it really shows that at first when you look at things, you may see that it's a challenging, right? The challenge, the barrier of the culture, the barrier of the resource, the barrier of the structures of the system, of those actors involved. But if you look further, you can see that it's not only the challenge, but also the opportunity. Exactly. It's a big challenge for us, but also an opportunity for us, and we have to show that how we can change, how we can get that new skill, new strategy, so we can really work with this challenge and turn that into opportunities.
Okay.
Yeah? Thank you.
Think now it's my turn because it's unfair. She keeps asking me. Now I want to ask her. Okay, are you agree? Do you think it's fair?
Okay.
Okay, now my question to you, I think is very difficult. What is one...
Too easy question.
Listen. What is the one burning thing that you wish we had discussed more within this conference or beyond?
Okay. Yes, I have one thing right here. Justice. Yes. When we come to this conference, I'm in the ISC committee, and we discuss a lot what should be the theme of this time. And many of us mentioned that we should continue to work on sexual reproductive health and rights. But then we said that rights maybe not cover the thing that we really want to do. And then we use the word justice. You can really see that in this time we don't have the word right in the title. So we mentioned justice, and you think that this may be a good, how to call it, like a term or concept that help us to achieve what we want to do, to achieve the thing that we want to do, leave no one behind. But somehow I see that in this conference, we not discuss the term enough. We not really discuss how you can really define it, how you understand it, and what is the advantage and disadvantage in comparison with right. I still see a lot of the right still quite overwhelmed in, use a lot in this, and we just like take it for granted, right? So then I think that and then the thing, we cover a lot of the group here, but then there's still some group that not really mentioned a lot, like elderly people, like bisexual people. Yeah, so in prisoner, you did have a group working on prisoner or other clothing, group working in closed institute, closed setting, but it should be more. Yeah, and we discussed about, I think there's some...
Closer.
Yeah, some lecture, like speaker talking about intersectionality and inclusivity. But I don't think that we cover it, we discuss it enough. Why it's a key strategy? I think intersectionality should be the key strategy. But we not really take it further from the plenary to the parallel session or to the satellite session. I think that we should discuss further. And inclusivity. It's not just about the inclusivity of the group, like a marginalized or this vulnerable group. But I think inclusivity can be understood as like how it can be open mind. Like here, Let's take the example of abortion. We just assume that we come here as people who share similar thinking.
No.
Yeah, we have the same standpoint, but it can really show, like the first distress, the first upset that we got, just from a dance. It caused a lot of misunderstanding. It caused upset. Yeah, and it may make us, it can destroy our solidarity. So it's really call for the important. It really shows how important this kind of conference, this kind of discussion is. And we should have the next conference where we can get together to discuss this more. Yes, so we will come together in the next conference in 2 years in Cambodia.
Yeah, actually, we don't have enough time to hear everybody sharing, because we're sure that many people here want to share about their impression, about their idea, but we don't have enough time. But we have our Facebook, right? You can write your thinking about the conference, about the thing that we need to do more, the thing that we need to be more creative, the thing like we need to be more, we get more understanding, more tolerant, more openness, things like that. Please share your idea, your opinion in our Facebook. Okay?
Yeah. We want to hear everyone's voice, so no one is left behind. Thank you.
All right. Thank you. Thank you very much, Ms. Hong and Ms. Wang, for your very creative and interesting summary. Now I would like to invite on stage Professor Rosalia Scottino on stage to share and conclude the conference programs.
So I have to thank all of you for being here up to today. I confess I am exhausted from these 4 days, but at the same time energized by the interest, the quality of the speakers, the full participation of the audience. I mean, all the parallel, all the satellites were full up to the last day, which is quite an amazing achievement considering we are an Olam Bay. People want to go on the boats outside. There are many distractions, but still this was a very engaged conference. I also learned a lot from what has been said. You never end with the learning process, and indeed I look forward to continue this learning process in Cambodia and beyond. I have to thank all those that helped me, and starting from the International Steering Committee members. Few have left, few are still in the public. So we had a lot of discussion. I can assure you some of the discussion were not easy. It's very difficult to have people with different background, different idea, different countries, different culture, all together and all think that we know best, because of course we are very convinced of our own idea. So to reach agreement, you have to go through that process, but I think we have managed to get agreement to focus on a very important topic, and I think the conference, all in all, reflected consistency very well. All the different plenary parallel satellites have contributed to a greater understanding of what it means. As was said before, we have not finished that, but it has been reflected. It's a good start because of the consistency, which reflect how the International Steering Committee has come together into preparing for this conference. Now, this would not have been possible without the great help of the local Secretariat, Professor Le Fouan, and I need to thank particularly my alter ego, which is Nga. Where is Nga? Yeah. And of course, Tran and all the other people. I think I will have some problem now that I live without Nga. I will miss her. I will feel one part of my body is no longer there because I have worked with her so intensively night and day. I can assure you she works even in the night. You can receive a message at 1 o'clock at night. And I am awake too by the time I get the message. So I am very thankful, and of course we are very thankful to all the volunteers. Where are the volunteers? The communication team, the friends, colleagues, new friends that are here, and grateful also to Natalia, with whom I have worked together at the Ford Foundation, and we are good friends, and she really made an effort to come here and share her new vision from the future. So this would not have been possible without all of you. Thank you again, and see you in Siem Reap, Cambodia.
Thank you very much, Professor Rosalia. As you may know, it is the traditions of the country in Asia-Pacific region to take turns and host the next conference every 2 years. And this will be a big honor, but also a very huge responsibility for the hosting country to take. So after a long process of considerations, we are very happy to announce that Cambodia will be the next host of the APCRSHR9. And the hosting organizations will be Reproductive Health Association of Cambodia, RAC. Yes, congratulations. And now please join me and look on the screen for the short video clips about the RAC organizations. feedbacks to the next hosting countries. I would like to invite Dr. Vaj Yvonne and the whole team of RAC associations on stage.
So, good afternoon, everyone. You know, the International Steering Committee announced in the website expression of interest for let's say, to the NGOs all over Asia and the Pacific. There were about, I guess, 6 bids, and the ISC voted for the Reproductive Health Association of Cambodia, which is RAC, and this will be held in 2020.
And now I would like to join me and give a round big applause for Cambodia and the Reproductive Health Association of Cambodia. Congratulations. And now I would like to invite Professor Dr. Vaj Yvonne to have some word with all the audience in the conference today.
Yeah, thank you very much. Thank you very much. Yeah. I would like to take this opportunity to thank Professor Lê Vũ Anh, the convener of the 9th Asia Pacific Conference on Reproductive, Sexual Health and Rights, and all the members of the International Steering Committee who have entrusted RAC for tasking with the organization of the 10th Asian Pacific Conference on Reproductive, Sexual Health and Rights. And I would like to take this opportunity to congratulate the Vietnam Public Health Association of making this conference a success. And I look forward to continue to learn from your experience and your support to make another successful conference in Cambodia. RAC is one of the largest sexual and reproductive health and rights non-governmental organizations in Cambodia, and we are the Cambodian member of the International Planned Parenthood Federations. Through the past 20 years in partnership, cooperation with the other civil society organizations and the development partners, RAC have pioneered with many components of the sexual and reproductive health and rights. For example, we pioneer in introductions of the community-based family planning distributions in the communities. We introduce and expand comprehensive reproductive health and clinics. And we introduce on the youth health, and then we progress to the comprehensive sexuality education. We also initiated and introduced quality service, friendly service for men have sex with men and transgender people. And with the other civil society organizations, we work in partnership with the government to make the Cambodia a more accessible, and make an environment which is more accessible to the reproductive health and rights in Cambodia. Through our collective works, Cambodia has a lot to show and to share, given the progress that the country have made in the progress in sexual and reproductive health. but I'm sure we have a lot to learn. We have a lot to learn. I'm sorry about this. While Cambodia's socio-economic progress is catching up that the more developed countries in the region, I am looking forward to working with you and each of us who are scholars, activists, women group, young people networks, network of various population groups, private sectors, and other institutions, and the government to continue the progress of our path, the path toward leave no one behind. Siem Reap province is the home of our numerous national heritage, including Angkor Wat, the World Heritage. And I'm honored that I have the opportunity to host the 10th Asia Pacific Conference on Reproductive, Sexual and Rights in Siem Reap. And I look forward to welcome you all in Siem Reap, Cambodia. Thank you. Yeah. And I would like to show you a brief video of 6 minutes. Yeah, you bear with it. Thank you.
The Reproductive Health Association of Cambodia, RAC, is an indigenous Cambodian non-governmental organization, NGO, which was established in 1996 with a strong determination to bring quality health services to the community, especially for the poor and vulnerable sections of the population. We are the leading in piloting and introducing SRH service, including MSM-friendly service and youth-friendly services, as well as our first ever study on an introduction of TG-friendly services, which paves the way for similar services provision in the country. Today, RAC is implementing its programs in 11 target provinces and cities and in 26 operational districts nationwide. RAC has 15 non-profit clinics that provide a full range of quality services in sexual and reproductive health. Since its inception, in addition to serving general population, RAC has been and continues to be the pioneer to work with factory workers, entertainment workers, transgenders, and young people, delivering friendly services meeting their various needs. RAC has been playing an important role in promoting family planning through its community health programs.
ការៈបាទគឺមកផ្សព្វផ្សាយពីជំងឺរបេងបាទក្នុងភូមិរបស់ខ្ញុំបាទដើម្បីនឹងពិនិត្យកំហាបាទហើយពិនិត្យអ្នករបេងដើម្បីនឹងព្យាបាលទៅក្នុងមណ្ឌលហើយខាងអង្គការៈនឹងធ្វើការស្រាវជ្រាវដើម្បីរកឲ្យឃើញនៅមេរោគជំងឺរបេងនេះដើម្បីនឹងបន្តការព្យាបាលឲ្យអស់ជំងឺនៅក្នុងភូមិ
មិត្តអប់រំមិត្តបានមកអប់រំខ្ញុំបានទទួលចំណេះដឹងពីគាត់ច្រើនដូចជាកិច្ចការទៅធ្វើតែឈាមហើយនឹងការប្រើប្រាស់ស្រោមអនាម័យ
Youth Health Program. RA is committed to improving the health and well-being of young people in Cambodia through improving their knowledge on SRHR. We work closely with the Ministry of Education to pilot and integrate CSE in school curricula and roll out this subject nationwide.
ចំណុចពិសេសនោះតកតងនឹងការពារខ្លួនដែលមិត្តភ័ក្តិផងបបួលយើងរួមភេទក្នុងវ័យសិក្សា
RA Hotline can be considered as an effective way to provide confidential health counseling. Hotline is also used to promote RA educational activities. Workplace Health Program. RA aims to improve sexual and reproductive health needs of factory workers by working to provide integrated sexual and reproductive health and HIV/AIDS services to factory workers through RAC's clinic services, and to build the capacity of factory clinics to provide selected quality sexual and reproductive health services to their factory workers.
អប់រំពីការបន្តពូជការរលូតកូនកាមរោគជំងឺធ្លាក់ខ្យល់និងផ្សេងៗទៀត
RA has been contributing to improve people's health in Cambodia. We want to ensure that sexual and reproductive health and rights are respected, protected, and fulfilled. RA continues to work further to partner with the Ministry of Health, Ministry of Education, Youth and Sports, Ministry of Women's Affairs, Ministry of Labor and Vocational Training, local and international organizations to achieve sustainable development goals.
Okay, so this came to conclude the 9th Asia-Pacific Region Conference on Sexual and Reproductive Health and Rights in Vietnam. Once again, thank you very much, and we look forward to seeing you in the 10th conference in Cambodia. Thank you, everyone. And once again, let's give a round of applause to all of you, and thank you very much for spending time, effort, and all your hard work and the contribution and the dedication that you put into the program with us. Thank you very much.